This is not online. Oh, good. I don't want it to. Good morning, everybody. Welcome to the Division of Cardiology Grand Rounds. I have the pleasure to introduce the speaker today. I had asked Dr. Charlesworth to give a talk to the residents on the very important subject of fatigue risk management in the fall. And 3 hours, it was a dinner talk, 3 hours into the dinner talk, I had to leave and I was the first one to do so because everyone was talking about the subject. Dr. Charlesworth is an expert in the brain as a neurologist and did a fellowship in sleep. So after that talk, I reached out to Dr. Stadnick and Dr. Klein and suggested that she speak at our grand rounds to educate us all about the science of sleep and to share with her or with us her knowledge of fatigue risk management. So without further ado, I'd like to introduce Dr. Charlesworth, and I was asked 2 housekeeping items. Number 1, if you're in the room, please sign up on that plain old piece of paper using the pen at the back. And secondly, grand rounds next week is Dr. Drucker. So please register for those. They will be online. Dr. Charlesworth.
Great. Okay, thank you so much. I'm absolutely delighted to be here and to talk about this topic that's near and dear to my heart. I think it's particularly important for medicine as well as wellness. I will note there will be a couple reflection questions throughout the chat that I'm going to ask for some small bits of audience participation. So I have the chat open on my phone here at my side, and I'm also going to ask for some in-person participation, but very minor. Don't be alarmed. So. All right, there we go. My only disclosure is that I'm a consultant for Transport Canada Aviation Medical Review Board, and you may see many references to the aviation industry in my talk. We have a lot to learn from a fatigue perspective from them. I don't think that's a particular financial bias, but important to note. I have no other public or private industry disclosures. So in this talk, we're going to spend the first little bit reviewing the physiology of the sleep system and the circadian system in the body, and then understand the impact of fatigue and sleep loss on mental and physical health, as well as on patient care. We're going to identify some driving forces behind fatigue in a way that can help you address your own fatigue, and then finally discuss some fatigue risk management strategies and some resources at the very end. I think no sleep talk would be a sleep talk without some reference to literature. So this is Shakespeare's Macbeth, Act 2, Scene 2. Sleep that knits up the raveled sleeve of care, the death of each day's life, sore labor's bath, balm of hurt minds, great nature's second course, chief nourisher in life's feast. And I think this is such a beautiful metaphor and really captures what sleep can be for us when it comes to fatigue and when it comes to resilience. I particularly appreciate the metaphor of knitting up the raveled sleeve every night when we go to bed, knitting up our thoughts and our emotions. So starting with some sleep physiology, you may be familiar with the old nomenclature for sleep, which is typically what we learned in medical school, which is stage 1, 2, 3, 4, and REM. That's been condensed in the newer ASM criteria to just N1, 2, and 3. The reason for that is stages 3 and 4 physiologically are essentially the exact same thing. It's not really much other reason than that. Throughout the night, you have sleep cycles that you descend through various levels of sleep, downwards and upwards. And on average, these are 90 minutes, but throughout the night, they lengthen and they change in their constitution. So sleep is a dynamic process. You spend most of your night in stage 2 sleep, a little bit in stage 1, and then about a fifth to a quarter in your deep N3 sleep, in your REM sleep. This also changes a bit as we age. Note that this is a logarithmic scale here. So we have a high proportion of non-REM deep slow wave sleep when we're younger. Then as we get older, that really drops off. And that's a combination of internal physiologic factors as well as just the technical factors when we score it on the PSGs. Whereas REM sleep tends to be relatively stable, aside from a period in youth, young youth, throughout our healthy lifetime. Although in some conditions like Alzheimer's, dementia, and other neurodegenerative states, REM sleep will decline as well. So we're starting with non-REM sleep. N1 is a light kind of drowsiness. The eyes start roving. People may be familiar with this because usually you retain awareness. And maybe even some people who are particularly sleep deprived may enter N1 sleep during this talk, and that's okay. I won't take it personally. N2 is your proper sort of deeper sleep. So N2 is heralded by these big, they're called K complexes and sleep spindles, which look pretty neat and physiologically are even neater. So these are really clear rhythm generators deep within the thalamus that spread throughout the brain. And these are associated with motor learning. So after learning a skill, your spindle density substantially increases. And interestingly, also during the luteal phase, and the exact mechanism for that isn't entirely known. So sleep spindles are important structures, but there's a lot of mystery still there. Your deepest sleep is your N3 sleep. These are these high amplitude delta waves, which means that the neurons are acting very, very synchronously in order to gather that this voltage, essentially. There's a strong role in memory consolidation, and rather actually than connections, it's more about culling synapses. So in order for us to have a nice potentiated synapse in memory, we need to get rid of the junk. And so N3 more so clears the extra as opposed to potentiates the ones that are existing. And in fact, in some conditions, particularly in autism, N3 sleep is much lower in kids. And remember, N3 is so high in kids, the thought is to build and cull those synapses. And so in conditions with high connectivity and high level of synapses, there's lower N3 sleep. Cause and effect is not entirely known there, but it's interesting that there's an association. Finally, the very important part of N3 sleep is waste clearance. So this is a new area of sleep medicine and neurology. It was identified in around 2016, and since then it's just been rapidly expanding. So this is a pseudo-lymphatic system of the brain that's governed by glial cells, hence the name lymphatic system. Dysfunction of the lymphatic system is linked to several disease states, so Alzheimer's, multiple sclerosis, traumatic brain injury, and even migraine. Really fascinatingly, this is linked to N3 sleep. And in fact, the pulses and the waves are coupled with your delta waves. And so essentially you get these pulses of blood flow that causes extravasation of water that pulls the solutes and the metabolic waste out into the CSF and then drains. And it's particularly interesting that this is time linked with those delta waves. Something physiologic is happening to clear that waste. And so we know that healthy N3 sleep can be protective. And in these diseases, it tends to taper off. And again, cause and effect, we don't exactly know, but there is an interesting link there. Our other major stage of sleep is your REM sleep. And most people are familiar with REM. It's your dreaming sleep. And I like to think of this as a cognitive playground. So this is associated with these so-called eureka moments. It essentially replays the day. And so, for example, if you put a rat in a maze and you watch it as it sleeps, the neurons that are figuring out the maze and following the paths will light up again. Same thing in humans. If you have them go through a particular topic throughout the day and you put them in an fMRI when they're sleeping, the same areas in the brain will light up during REM sleep. There are a couple famous associations. We can't say for sure whether or not these were associated with REM sleep, but this is Friedrich Kekule, who was a German biochemist. Sorry, no, this is Mendeleev. My apologies. Mendeleev and Mendelev's periodic table of the elements famously came to him in a dream. And this is the benzene ring. That was Kekule, who awoke from a dream of a snake eating its own tail and came up with the structure of the benzene ring. And another quotation that I particularly like from this: if we learn to dream, we may find the truth. But let us be careful not to publish our dreams until they have been checked by the waking mind, which I think is good advice. Dreams can be quite crazy at times. REM sleep, because you're dreaming and your brain is in this wake and very active state, you need to be paralyzed. So it is associated with full body atonia. Here's a polysomnogram of your EEG leads, eye leads, limb leads, in normal phasic REM sleep, meaning that these eye movements are choo-choo-choo-choo-choo all over the place. This is a 30-second epoch. So every little flick here is the eyes moving. Whereas the next image here is REM without atonia. So this is a person whose brainstem is not properly shutting off their body in their sleep and they're acting out their dream. So this is called REM without atonia, which the sleep itself is normal. The problem is just the lack of atonia, and this is associated with some disease states like Parkinson's disease and MSA. Finally, for REM sleep, this is a standard stock image of Google neutral expression, is associated with emotional regulation and introspection. And in fact, if you deprive people of sleep, and specifically in subsequent studies, they've deprived people selectively of REM sleep, meaning you wake them up just only when they enter REM, but you let them get the full 8 hours of sleep, people have lower capacity to identify emotions on facial images that are shown to them. And so that feeling of emotional change and emotional difference when you don't get enough sleep actually is borne out likely because of a contribution of REM sleep, which helps your brain really integrate these emotions into your day-to-day life. When you lose sleep, your sleep structures can change and your sleep stages can change. So your N3 on a typical night is front loaded. It's homeostatically driven. The more you're awake, the more N3 you need. It's front loaded in the night to help you catch up. And your REM stages early in the night are quite low. Quite short. And then later in the night, REM is more circadian driven, meaning the early hours of the morning, you will have more REM. Each of these can accrue debt independently. So if you selectively deprive someone of one stage of sleep, they will rebound to that stage preferentially. This is a hypnogram or a PSG of a patient that I saw. I think you can see it pretty well there. At the top, these are the sleep stages. So this person has very, very broken sleep. You can see why. And the next, the respiratory events, they're obstructing a bunch. This person has severe obstructive sleep apnea and their oxygen levels are not very happy there. The bottom line, you can see we started them on CPAP. This green stuff is REM. So this person went into 2.5 hours of REM as soon as he was started on CPAP and his breathing was stabilized. And more than likely, because sleep apnea is worse in REM sleep, when you have that atonia, this person was selectively deprived of REM sleep for who knows how long, and their body just completely rebounded. So you can accumulate sleep debt independently of each stage or together. N3, if you sleep deprive yourself of a whole night's sleep, N3 will preferentially rebound before your REM rebounds. Sleep stability is important as well, sleep stage stability, and it's driven both by circadian and homeostatic mechanisms. So depending on what time you sleep and how sleep deprived you are will affect your stage stability. When we think of sleep stages, I should also add wake is technically a stage of sleep if you want to consider it that way. And so orexin is this sleep stabilizer from wake to sleep. Simultaneously, you can't or are not supposed to be asleep and awake at the same time. Now, sleep stages can be destabilized by pathology like narcolepsy, which is a relative loss of CSF orexin. Sleep debt can destabilize your sleep stages and an irregular schedule. So sleeping when you're not supposed to be sleeping, when your body doesn't think you should, can really destabilize sleep. If anyone's had a long period of sleep loss, maybe residency or fellowship, and then you have crazy, weird, maybe dreams, sleepwalking, sleep paralysis, that can all be caused by an irregular sleep schedule. So the bottom line with all of that is, why do we sleep? We do not know. Who knows? We do know a lot of the benefits of it. And we know that sleep is not a passive process. It's not just a reset and pause. Oh, now I can go back to working. Sleep is very active and it's restorative for nearly all bodily functions. So this is a portion of audience interaction. I want to ask everyone here, and I have the chat open, just a couple words to think to yourself. How do you know when you're fatigued? Please just yell it out. Concentration troubles? Is anyone feeling fatigued right now? Cold, yeah, temperature dysregulation. Eyelid heaviness, eyelid drooping. Emotional instability, absolutely. Yeah, absolutely. Okay. It's going to be very independent and different for each person. Oh, and somebody in the chat said irritable. Certainly, the emotional changes, the ups and downs. So it's really good to know your own personal signs of fatigue because it's not going to be the same for everyone. There are some things that can help with fatigue self-assessment. There are some apps, there are some questionnaires and scales. Nothing is particularly validated. And so I would more go along with just the introspection, the personal identification of what your signs of fatigue are. And I like to separate them into physical, mental, and emotional. And we actually had a really good smattering of each in this audience. I've done this talk before where it was really focused more on the emotional, really focused more on the concentration. So it's good to acknowledge that all of these physical, mental, and emotional can be signs of fatigue, both short-term and long-term. And so some additional physical signs to point out here would be the recurrent illness or injury, and we'll talk a bit about why that comes in. So consequences of fatigue. First, we have to define fatigue. There's no clear definition. In general, it's a physical, mental, cognitive sensation of tiredness associated with some sort of an inability to perform a task. Operationally, when we're considering occupational medicine, it's an increase in variability of performance. So think about maybe a procedure that you have to do. When you're fatigued, you may do it okay, or you may be impaired, and that may be variable. Or if we're thinking about other industries, pilots on a runway in a simulator, hopefully, they may have increased variability in their ability to land the plane in a safe way. So overall fatigue, though, it does reduce the ability to perform work safely and effectively, and fatigue is well acknowledged as an occupational risk of healthcare. So we talked a bit about the cognitive effects. Emotional is very linked with fatigue and sleep loss, and specifically REM sleep loss. So this can be seen in reduced empathy, challenging to interact and empathize with patients when, you know, it's 5 a.m. and you just want to get to bed. Reduced introspection, and in general, just this sort of buzzword of resiliency. Fatigue can lead to this sort of poor cognitive and emotional resiliency. Functionally, there's lots of studies that have shown reduced reaction time with things like the psychomotor vigilance test, decision making. I remember when I was a new senior resident, I always tell the residents the story. I came to a snowbank right in the middle of the sidewalk, and it took me about 15 seconds to decide which side of the snowbank to walk on when there was absolutely no implication of either direction. And so that's an example of decision fatigue. I don't know if you've experienced something similar to that, but after a long night on call of sleep deprivation, it can be very challenging to make decisions, even simple ones. There are very clear systemic effects of fatigue. I don't have references on this slide because there's far too many, but I'm happy to provide them if something stands out here to you. So with regards to immune function, the World Health Organization declared shift work and fatigue a probable carcinogen in 2007. And it has been linked independently to colorectal, breast, and prostate cancer, even when controlling for other factors, including socioeconomic. This possibly is related to the effect on sleep deprivation of reduction of natural killer cells by about 70% the following day, and it slowly recovers over time. There's also been shown a weaker antibody response to vaccines. So both in the short term, the antibody response, as well as up to a year later, there was a particular study looking at young men with their hepatitis vaccine, T helper cells, as well as antibody response. Fatigue has been shown to be linked with metabolic syndrome, insulin resistance, obesity, cerebrovascular and cardiovascular disease, hypertension, infertility, and spontaneous abortion as well, some fertility implications of fatigue, and then as well as just simple serum biomarkers. So C-reactive protein is higher, has higher levels in people with even just a single night of sleep restriction. It's pretty severe sleep restriction, less than 4 hours, maybe that's not severe in our group, but for the general public, as well as total tau and neurofilament light chain, which are both CNS biomarkers of neuronal damage. Specifically in healthcare workers, there is some evidence. So physicians do perform better than the general public in settings of sleep deprivation. So that feeling that you feel that you can do a good job when you are sleep deprived, it holds up. This is likely not because physicians are more resilient or resistant to sleep deprivation, but because physicians are used to sleep deprivation and have built-in cognitive checks. The total work hours correlate with both sleep loss and reported stress hours. The longer you work, the less you're going to sleep. That's sort of relatively straightforward. I think most people understand that. And this one was particularly interesting, I found. So physicians who average less than 5 hours of sleep per night on a week-long basis report feeling less satisfied with their work, feel more impaired subjectively, and are more likely to feel belittled or humiliated at work. And again, this is an association. Who knows what the cause here is? But thinking back to those emotional components of fatigue, of REM sleep, of sleep deprivation, it's interesting that that can kind of pervade into life, both professionally as well as patient care. Specifically in resident physicians, they're a group that are very can be very sleep deprived. There have been a couple, well, many studies on resident shift restriction, hopefully to increase sleep duration. So duty hour restriction. And there's just, the bottom line is very, very mixed evidence. There are some benefits, for example, fewer prescriptions, slightly lower length of stay, fewer medication errors. But there was this Medicare study in 2007, which followed the ACGME duty hour restrictions in the United States. So this was an 8.5 million person people were included in this, and there was no clear benefit on 30-day all-cause mortality. So it's really a mixed bag. My personal suspicion is because if you look at duty hour restrictions, they're on a single 24-hour time frame or a month. And really what we need is a day-to-day type of restriction. So for example, if you're working 16 hours and you need to be back at work the next day, is that really better than 24 hours with a recovery day? Unclear. There have been clear demonstrations of negative impacts as well. So residents who have duty hour restrictions are more likely to perform poorer on standardized tests. This was a surgical cohort of, I believe it was OB/GYN residents, lower resident satisfaction, and lower confidence in procedures, likely due to lower exposure on the job. And so you do have to balance. It's not just about fatigue and wellness, although that's, you know, my main side of things. It is also about learning and patient care. And I think this is why we haven't moved quite as far as we would hope when it comes to resident fatigue. There are very clear cognitive implications of sleep deprivation. This is an image used with permission from Dr. Mindy Rush, is one of our neurologists, and she had a very, very, very busy night back in 2021, driving back and forth between the General and the Civic for multiple stroke codes, and had a quite significant car accident. Luckily, she came out okay, unscathed, but very rattled, of course, and just to kind of drive home the importance of fatigue management on the job, because we can't take care of our patients if we don't take care of ourselves. So this is a really, I really love this. This is a fatigue paradox. And this was a interview-based study that used constructivist grounded theory. So they interviewed nurses, residents, and staff physicians and came up with themes around physicians and nurses' ideas of fatigue in medicine. So number one, I think probably most of us will acknowledge this. We acknowledge that there are problems with fatigue. There are operational troubles, cognitive effects of fatigue on performance. We could say, yeah, when I'm fatigued, you know, my reaction time's slower. My emotions are maybe a little bit more volatile. Maybe, you know, I'm not at my best. But there is a general reluctance of people to take that and say, that will negatively affect patient care. And that's where we have the barrier. And interestingly, this is, if you look at sort of a series of M&M rounds, I don't know, you know, what it's like here. This was a study in the States. We are much less likely and historically less likely to address fatigue in our M&M rounds as an industry. And if you contrast this to other industries, safety industries like aviation, fatigue is much more likely to come up as an operational contributor in a not in a blame way, but just this is a side effect. This is an occupational risk. How can we address this? So this is a barrier, I think, in medicine. There are very clear problems in medicine, in healthcare workers, largely due to the nature of the work. So we cannot get around this. There will be accumulated sleep debt. There will be circadian dysynchrony, meaning you are sleeping at a time when your body does not want to sleep or is not used to sleeping, and you'll be awake at a time when your body wants to sleep. And then all this busyness and all this emotional stress and cognitive stress can lead to poor coping strategies. So to manage fatigue, which we'll spend the rest of the talk on, We want to limit and adapt to sleep restriction, recuperate quickly, and understand how to optimize our circadian systems. So that's going to be the second half of the talk. So I want you to think about how you sleep on weekends and how you sleep on vacation. And you can throw it in the chat if you want, or more just sort of ponder this. Most people sleep in on weekends when they don't have that time that they have to get up. Some people do go to bed much later. They'll kind of shift a bit. Some people have a nice consistent sleep schedule. And then on vacations, if you tend to shift more and more, that's a bit more of a circadian sign. So you can use this to kind of do a bit of a self-assessment of your sleep requirements. So if you're sleeping more on weekends, you probably are a bit sleep deprived. And if you're shifting on vacations, you probably are of a particular circadian type. So when it comes to sleep requirements, knowing your sleep requirements can help you perform better in the healthcare setting. Not everyone needs 8 hours of sleep. It's a bell curve with 8 right in the middle. And everyone loves to think that, oh, well, it's like 7 to 8 hours of sleep. If I get 7, that's fine. But some people don't need 7. Some people need 9. Just as many people need 7, need 9 hours of sleep. And how many people here actually know people who sleep 9 hours of sleep? Probably not many. I do. So the normal range is there. Most younger people do require more sleep. So particularly, for example, in our resident cohort, residents most likely need more sleep, like 8 to 9 hours, especially because of the cognitive load and emotional load. It is exceptionally rare to truly function on less than 6 hours of sleep. So if you put people in an isolated environment and let them just free run and sleep whenever they want, first of all, 96% of the population will sleep between 7 and 9.5 hours. Some people will just hold themselves to 6 hours. And then if you test them on psychomotor vigilance tests, decision-making, logic problems, they will still perform well. Then if you take a cohort and you restrict them to 6 hours and you test the general cohort, nearly everyone will perform poorer on 6 hours of sleep, even people who say that they perform well on 6 hours of sleep. This was not specific to physicians. There are long-term impacts of sleep restriction, and these are juxtaposed very often to the reason for sleep loss. So the term that's commonly used in social media is revenge procrastination. That idea of my day was so busy, I just want to watch my TV show. Or, you know what, I have not had the chance to be physically active at all. I need to get a workout in. My sleep can wait. And some of these are healthy habits, and it's okay to push sleep. But I want you to think of sleep as an active choice of wellness, not just something that can be pushed to the side. There are some ways to get the most out of your sleep. I don't want to belabor this too much, but just some quick tips. Number one is a consistent schedule absolutely helps everyone. So prioritizing sleep. If you have an alarm that you snooze, you're interrupting your last portion of sleep. Just set your alarm at the very, very, very latest that you can get up and get that nice interrupted sleep. I have some patients who snooze their alarm for an hour. It's like, well, that's an hour you could be sleeping. One time's okay. That like bliss when you're like, oh, great, just going to go back to sleep one time. Evaluating sleep hygiene. We won't go into it in too many details, but there are some good tips about the temperature of your room, light exposure, etc. mysleepwell.ca is a good place to start. Avoiding substances. So caffeine should not be taken afternoon. Our bodies variably process it. It has about a 5-hour half-life, longer in some, shorter in others, but in general should be avoided afternoon. And alcohol after 1800 destabilizes sleep, even a single glass of wine, for example. And then naps. That is the next part of this topic. So what about naps? You hear they're great, they're awesome, power nap, and then you also hear, not so great. You get this inertia when you wake up. So how can you actually nap? There is clear benefit of napping. So short naps during active learning will increase memory retention, and that's been shown pretty robustly. I really like this study. This was one of the earlier ones that I could find, 1924, obliviscence during sleep and waking. So obliviscence is the sort of the absent-mindedness, the act of forgetting. Short naps when learning a motor skill. So in one study, they looked at people who had to type a particular series of numbers. I think it was a string of about 9 numbers on a keyboard. People would consistently run into a break at the same point, you know, just that tiny little cognitive break that you can't quite string them together. You sleep and then it's nice and fluid. The real life example of that would be thinking if anyone's a musician here playing the piano, you get to that like point in your music where you get stuck and then you keep going, sleep, and it smooths it over. Naps can bridge some of the negative effects of sleep loss. So it's quite well known. You will be more alert after a nap as you clear the negative effects. But there are risks, and some of you may be familiar with this. So if you sleep too late, your nocturnal sleep will be worse. You're decreasing that homeostatic sleep drive, harder to get to sleep at night, fairly straightforward. Napping too long will cause this really dense kind of sleep inertia. It's really, really hard to get up. You're dragging yourself out of bed, and that can be dangerous. And in fact, that decreased attentiveness, that sleep inertia, can last up to 90 minutes after you wake up. So if you nap too long, there truly can be negative cognitive benefits. So this is one area where the aviation industry has done things really, really well. This was a NASA technical memorandum, 1994, and they did a series of these. They looked at both when to nap, how long to nap, do you nap, because there is that risk of napping. So how do you optimize a rest period? So they looked at pilots in long haul flights, so 18 to 36 hours, naps at the beginning, middle, end of operation versus no nap. And then they measured drowsiness objectively, EEGs, EOGs to look for those roving slow eye movements, and EMG to look at low chin tone. So pretty sensitive rather than just asking somebody if they're tired. And so think about that. So first of all, naps performed better than no naps. So that's fairly straightforward as long as it's short. But second of all, if you think about you have that long period, this can be akin to a long call, for example. Do you think it's better to nap at the beginning, middle, or end? Most people would say middle or end. You kind of like recuperate what you've lost. But in fact, there was much better performance at the beginning. The idea of this is that you prophylax your sleep debt. You come into it starting at the best portion that you can be, or the best level that you can be. And this is called prophylactic napping. So 20 to 40-minute nap at the beginning of a shift or an operation actually has the best outcome. Interestingly, because they had these measures, they could tell if the pilots were truly sleeping, and some of them did not sleep, and they still had the alertness benefits. So even if you just have 20 minutes to lie down, you know you're not going to fall asleep on call, on shift, whenever it is. You can still get some alertness benefits. They called these prophylactic naps. Talked to the FAA. FAA was like, no, there's no chance. Our pilots aren't going to go for that. So they said, okay, planned naps. I said, no, that's too managerial. So that's how we got power naps. Pilots, fragile masculinity. All right. So chronotype. So this is the second portion of the acknowledging your sleep debt and accustoming to your fatigue levels. So think to this. Most people know if they're a morning person or an evening person. Most people identify as evening people. But I would challenge you and say, are you saying you're not a morning person because you're just so tired in the morning? So is it actually sleep debt that's telling you that? So more so think about, does that differ from your period of productivity? Do you like to work more in the morning? When you can drag yourself out of bed, do you actually get better work done? So really these productivity periods are sometimes a little bit more reflective of our circadian rhythms. So circadian cycle is not the same thing as sleep and wake. We often think about them as similar, but they are two distinct things. Sleep-wake cycle tends to be a portion of your circadian cycle, associated with alertness and somnolence. But everything else cycles on a circadian rhythm as well. So your socialness. Some people like to socialize in the morning versus the evening. Blood pressure levels, quite well known in cardiology. Presentations with stroke or heart attack at a particular time of day. Even asthma attacks tend to follow a circadian predominance. Food intake and your hunger cues, your hormonal cues, as well as body temperature very clearly fluctuates with your circadian rhythm. And everything on Earth has a circadian rhythm, including plants. So your diurnal animals like us, giraffes, penguins, then various nocturnal marsupials also have a circadian rhythm in the opposite direction. Interestingly, melatonin helps drive your circadian rhythm, and it's high in both of these creatures at night. So whether you are awake or asleep at night, if you're nocturnal or diurnal, the melatonin is high. So we often think of melatonin as a sleep hormone, but it's not. It's actually a circadian hormone. When we think about sleep and the circadian system together, we call this the two-process model. So process C is the circadian drive for wake. We're probably kind of about right here. We're kind of on our way up to a more awake state. And then it kind of comes down in the night, up and down. And this is the natural background rhythm that runs day to day. It does look a little bit more like this with that post-lunch dip and an evening peak. But for simplicity, we're going to say it's this. And then process S is the homeostatic accumulation of being awake. So this is essentially adenosine that builds up in our synapses and causes you to be groggy. And that's what needs to be cleared by sleep. So we're probably all familiar with this. The longer you're awake, the more fatigued you are, you go to sleep, and it actually clears pretty quickly. And maybe this is why, if you have an awakening pretty early in the morning, it can be harder to get back to sleep because you've cleared all of your homeostatic drive. And when you superimpose these together, you get a sense of your sleep-wake rhythms when it comes to the circadian system, as long as they're aligned. And when they're the furthest apart, so you have the highest drive for sleep and the lowest drive for wake, that's our natural bedtime. But if you force past that, for example, you're on call or you're on a shift, and they're the furthest away, that is when you will feel the most fatigued. And most people will reach that nadir around 2 to 3 a.m., and it's heralded by your temperature drop. So that moment when you are so freezing cold and you go to find a blanket because you're so cold, that is your circadian nadir. And that can give you hints as well to your performance in other spheres, like your cognitive performance. So it's good to be aware of these physical cues as well. And then also to mention, as you go later in the morning, even if you don't sleep, you're up here, there's less of a drive for sleep. And that's why you can perform maybe a little bit better at 7 a.m. than you were at 3 a.m. So we tend to split people into these categories of morning larks and night owls. Most biological clocks are a little bit long. If we threw you in a cold, dark cave with no external information, everyone would cycle a little bit longer than 24 hours for the most part. And this is the tendency to phase delay. This is also when you're on vacation, for example. Some people will shift to their normal bedtime is maybe 9 p.m. till 5 a.m. and now they're sleeping 12 till 8 or whatever it is. And then they shift back. So these are our night owls. This is prototypically our teenagers. Teenagers naturally have a much longer circadian rhythm. And then on the other side of things, less than 24 hours is a tendency to phase advance, meaning you put them in a dark cave and they cycle quicker than 24 hours. These are our morning larks. As we get older, our cycle shortens, and we are more likely to want to go to bed earlier and wake up earlier, not being able to get back to sleep. Light is incredibly important in this. So if we all just had a circadian rhythm with no entrainment, we would just kind of cycle all over the place. We'd be in phase and out of phase, and who knows what's doing what. Maybe actually that would be better. I don't know. So light is really important for this. It's what's called that Zeitgeber, which is time giver, and it cements your circadian rhythm in day to day. So it can be used to shift your circadian rhythm. If you are naturally a night owl and you want to be a little bit earlier, you can use light to your advantage. And it's probably more impactful for night owls. If you look at pupillary response, for example, people who identify as night owls they have a stronger and brisker pupillary response. So maybe there's something there that they react a little bit more, and that's why they tend to be pushed more by our society with all these bright lights and screens and everything. There's some benefits of light. So clearly independently increases mood. Think of seasonal affective disorder. There's reasonable evidence for bright light therapy in the winter, and alertness. So a burst of light, 10 to 30 minutes, 10,000 lux, does have lasting effects on EEG correlates of wakefulness beyond an hour after the light is given. So it can be used as a stimulant, kind of. Light in the wrong place can also be bad. So looking at people in a 100 lux room, which probably would be if all these bright lights were off, and maybe standing back here for that light. So it's like dim, but not dark. So a 100 lux room is associated with higher levels of insulin secretion and impaired glucose control in non-diabetic healthy young patients. So there is a metabolic effect of light as well. So you can use this information to your advantage and to help you plan. So if you know that you get freezing cold at 2 a.m., 2 a.m. probably isn't the time for thinking about that really complex case. And if it can even wait an hour, then you can use that, maybe do some charting or variability, a little bit of walking around rounds, whatever it is, and come back to that complex case when you are not at your very low nadir. Obviously, we can't coordinate that with heart attacks and stroke codes on my end. If it happens at 3 a.m., it happens at 3 a.m. You respond in the way you can. But even just acknowledging, okay, I'm in my circadian nadir right now. I need to be extra careful. Even that can be beneficial. You can also use this information to coordinate your circadian rhythm. So in neurology, we have a tiered call system. We have a staff and always 2 residents, juniors and seniors. So I always talk to my residents about coordinating. So, if they have a 2 a.m. consult, maybe discussing, okay, you take this one, you're feeling okay now, I'm going to nap, I'm going to get my power nap. And then, you take this one, I'll take the next one, however it works. Night owls will have their performance dip a little bit later, on average 3 a.m. Morning larks will be a little bit earlier. And on average, women will be a little bit earlier than men, even within those groups. So night owls, it's really important. In the morning, they're going to be a lot more tired, thinking about that delayed circadian rhythm. So having safe transportation home is really, really important. Whereas morning larks, they're going to be dragging their feet for a little bit longer earlier in the night and seem to be a little bit more prone to the effects of fatigue early in the night. So taking that into account when planning their fatigue management. Day to day as well, even not on call, clinic days, or even just a day at home. Knowing your efficient periods can be really helpful. So plan your boring, rote work, the stuff that you can just click through in your sleep, plan that at that circadian nadir, 1 to 2 p.m. And then plan your more complex things around that. You can also plan your wellness. If you know that you really, I love to just zone out and do a workout, I'm going to do that in my period of lower cognitive period in the lower dip maybe. Night owls and morning larks, everyone benefits from a consistent circadian cycle with a consistent wake up time. Night owls will particularly benefit from immediate morning light to help cement their rhythm because they're more likely to drift, whereas morning larks can use evening light to their advantage to help them get that alertness if they're really fading. Night owls should absolutely avoid evening light at all costs. This is probably why most of our population is phase delayed, we're ever so slightly, and then everyone pushes themselves even further from screens and lights and everything like that. And then finally, on shift, this single slide does not do it justice. There's actually a lot of literature truly how to master your circadian rhythm on shift, but just an overview here. So when you are off your circadian rhythm in a completely different way, let's say you've traveled to Ireland, your circadian rhythm will slowly catch up. It'll truck along at about an hour a day. And so you may even notice next time you travel, pay attention to that really, really cold period. It'll slowly shift backwards or forwards in the direction of your new circadian rhythm, and it'll take some time. And if you aren't paying attention, you might just think, oh, I'm just really cold. Oh, it's cold out here today. And oh, this is 2 a.m. back at home. There we go. That's my circadian rhythm. So it'll slowly truck along and catch up. So when you're on shift, if you have a long period of shift that is in aberrance to your natural circadian rhythm, you can shift yourself purposefully in anticipation of that. And even if you can't shift yourself the whole way, even a little bit of later and later with light and melatonin, there's some nice resources for this. You can talk to me at the end if you want some, that can help you shift to accommodate that upcoming shift. Now, most of us don't have like 2 weeks of shift works. That's in other industries. We tend to be more of the rotating shift. So rather, you just have to have methods to accommodate it. So if you can have an overlapping core sleep, your sleep will be better during your circadian period that anticipates sleep. So for example, when you get home immediately, you're still in a little bit of that sleep window. So getting some sleep quickly there will be more restorative than a random sleep in the middle of the afternoon. And so having this core sleep with a few naps can be helpful. Stimulants also can be used with care. And in fact, modafinil, for example, not quite a stimulant, but a wake promoting neurochemical, can be used with care, and it's on label for use in shift work disorder. Also, all of these other things that we talked about for mitigating sleep restrictions. So we'll go through that. So now that we have this knowledge of how to accommodate your sleep debt, we know the potential side effects of sleep accumulated sleep debt and fatigue, but it is still an occupational risk. Just because I've told you that we don't function well when we don't have sleep, it's not going to change essentially anything about our scheduling. So how do we actually take this and put it into real life? So the first thing that we just went through, plan accordingly. You now know your circadian rhythms, hopefully, maybe paying more attention to it in the days to come. And you can optimize your activities to that as much as possible. Sleeping in pre-call or pre-shift can be exceptionally helpful. It's kind of akin to that prophylactic nap. You're just tacking it on to the end of your natural sleep cycle. So if you have the capacity that, for example, booking clinic patients a little bit later or coming into work a little bit later just to get even an hour extra of sleep before the call shift can be very helpful. Stimulation can also be very helpful. The most common one for us is caffeine. We have a lot of caffeine. Tim Hortons second cup, it's awesome. But caffeine can really have negative effects as well. And especially once you accumulate beyond 18 to 24 hours of sleep debt, the negative effects vastly outweigh the positive. So jitteriness, anxiety, things like that. So preferentially prioritizing light can be a good idea. Remember, there are these independent associations with alertness. So light may be great later in the shift as opposed to caffeine. Nutritious snacking has benefits on alertness. Cold water in the face. This was a study with napping and cold water in the face, but it was 2 minutes of cold water, which I think is an interesting decision and not really something I'm going to employ, but there you go. And maybe, who knows, maybe even 30 seconds of cold water is sufficient as well. Social interaction can even be an activator. Activity breaks and then varying tasks to keep yourself cognitively engaged. And then there's the nappuccino, which I think people have known about colloquially, but there's actually evidence for the nappuccino. I don't think it's called the nappuccino in the studies, but anyway. So this is a bolus of caffeine, which is about 250 cc's of coffee, which is around 100, it's 80 to 120 milligrams of caffeine. It reaches peak serum level of 20 minutes, and acknowledging that your sleep inertia, that like dragging sensation of sleep pulling you when you wake up from your nap, that'll start around 30 to 40 minutes. So you take a bolus of caffeine, go to sleep, wake up 30 minutes later. The alerting effects of caffeine should be able to help overcome that inertia that you might build, and you will have the alerting benefits of the sleep. So that's the nappuccino. All right. Now, how do you combine these things together? When it comes to recovering. So keeping in mind your circadian rhythm can be helpful. I think one of the important things that we often don't acknowledge is if you have sleep debt, you can't just pay off the sleep debt immediately by sleeping a little bit extra. You have to accommodate it several days in a line. So this is the FAA advisory circular that came from some of the evidence from those NASA studies. And so this is an example of a pilot on a long operation. So you can see here that they get extra sleep time in this gray period leading up to it with their circadian rhythm. They get the drop on their mission, on their flight, with a couple naps, and then over the next couple days, they're slowly recovering back to baseline with increased 9 hours here of sleep recovery. So night owls will have more of a natural sleep period when they get home from a shift. So night owls will have benefit from a longer nap in the early day, and they will have much harder time recovering with this 9 hours of sleep at night because they're naturally shifted in the other direction. So maybe there are people who will do better with a nap longer with a little bit of increased nocturnal sleep. Whereas the morning larks, they're people who won't really have much of a trouble increasing their nocturnal sleep by going to bed earlier. So a shorter morning nap may be reasonable, but it really is personal on an individual level. From a longer term perspective, I think keeping an open culture, open discussion is very important. Being aware of ongoing signs of fatigue for yourself and for your team, and avoiding the use of stimulants and coping strategies long-term can be very helpful. Acknowledging sleep requirements are very important. I'm realistic. I don't think everyone here is going to go home and get 9 hours of sleep every single night for the rest of their life. I don't get 9 hours of sleep every single night. But I think setting a goal for yourself. So I try to stick to about 4 to 5 days a week. I try to get my natural sleep requirement, whatever works for you. And you can play around with this and sort of figure out what your needs are now that you have some extra data to help you. Addressing any underlying sleep disorders. So some people, even if they get enough sleep, they're still very, very, very tired. Sleep disorders are very common in our general population. And so if something doesn't seem quite right, we're always happy to see people in the sleep clinic. There's a lot of sleep specialties all across Ottawa. So talk to your doctor. And then finally, thinking about this consistent schedule. The more consistent your schedule can be, the better. So just finally, a couple last slides on next steps. There is a role of the individual in fatigue risk management. As healthcare professionals, it is our responsibility to account for our fatigue and overcome where possible in our context, acknowledging that there's only so much we can do for that. So on shift, or even before a working day, before a clinic, conducting a fatigue self-assessment, just a moment to check in with yourself. What are my physical signs, jaw clenching, eyelid drooping, whatever it is, cognitive signs, emotional signs, where am I? And if you're particularly fatigued, declaring that to a team can be helpful, because even just acknowledging that a team is fatigued at 2 a.m. can be helpful to do those extra checks. Ensuring adequate rest and nutrition is obtained before heading into a period of known sleep restriction can be helpful. Avoiding shifts in excess of 24 hours, particularly for helping our residents to accomplish this, sending people home on time, and for ourselves when we're planning our clinic days, for example, post-call. Reporting fatigue-related incidents. This comes back to that fatigue paradox. If we don't acknowledge it, we can't change it. And so having fatigue potentially as a part of M&M rounds, even just to start to acknowledge it, can be very helpful. And then finally, employing these fatigue countermeasures that we discussed, all the various stimulation techniques. And then there is a role of leaders, of course, as well. The culture will not change overnight. And so building a better culture and a better system, I think, can be very helpful. So ensuring that fatigue risk management is a priority. I'm so excited to be giving this talk here. It shows that it's a priority in this institution. I'm super happy about that. Residency programs also are picking up on it, which is wonderful. It's just becoming more and more ingrained, and hopefully this will have some momentum moving forward. Allowing trainees and employees to contribute to fatigue management plans, acknowledging that everyone's fatigue requirements are very, very, very different, and providing napping and rest areas. This is a fairly straightforward one for people to get that power nap or prophylactic nap as needed. Culture and policy is very important. So whether there's some mandated breaks or check-ins, we already have so many checklists and things. So management may not be a dedicated management policy may not be the best here, but there are some things that we can do there. And more so, especially for residents, but even just thinking to yourself, a mandated pre-shift rest period. So all that to say, the basic goals of fatigue management. So we talked a lot about sleep physiology and circadian physiology. So hopefully you can use that information to understand the interaction of how this impacts your fatigue. Prioritizing sleep and limiting sleep restriction can be helpful. Plan day-to-day functioning with circadian optimization. Recuperating from sleep loss effectively can also be beneficial. And then performing important tasks at a circadian optimized point. Using coping strategies wisely when needed. So when you know you will be tired in that occupational low period, using the toolkit that you have. And then I have just some final slides of some resources. This is a Brightspace module on the U of O website that it's available to U of O teachers and students. So it's from surviving to thriving fatigue risk management in medical education. It is an excellent, excellent module. I personally am anti-module. Just modules in general, I find don't really have the they're hard to go through, but this is a great module. It's very well set out. It goes through everything that I went through. So if you want to go through things again, get the evidence, this is a really, really good one. There's a website, residentfatigue.ca. There was the resident task force in, I think, 2018, fatigue risk management task force. So they have a toolkit on there. There's a BMJ visual summary for shift work, and this is more kind of these consistent shift work schedules for some extra information there. MySleepWell.ca is through Dalhousie University and Queen's University, so it's an evidence-based set of resources. I always give this to my patients as well. Really, really good options for things like sleep hygiene. And then finally, my favorite resources, which truly these advisories, FAA, Transport Canada, these are beautifully laid out. They look almost dry because it's all black and white and just lines. Beautifully laid out documents, lots of take-home points from these that really can be applied to our industry as well. And with that, thank you so much for staying awake for my presentation. I appreciate it. And I'm happy to take questions.
I did see one in the chat. Can you see the chat?
Yes. So the question in the chat, could you address meditation versus nap as a pause during the day? So I'm not aware of the specific evidence, although I suspect that somebody has probably looked at this. I do know that if somebody takes a mindful pause versus a nap, they do still get that alerting benefit. And so I think it's just the matter of having that time, that unstructured time to recuperate. I'm sure that I strongly suspect that there is specific evidence looking at that, but I'm not aware of it. Going back to the pilot study though, pilots who didn't sleep, but did just have a restful period where they weren't supposed to be engaged in the environment, did have the alertness benefit. So I do suspect that there would be benefits from meditation as well.
Thanks for the presentation. That was amazing. I really enjoyed. Any comment about these apps on the smart watch that they track the sleep, and if there's a benefit of using it, then what do you recommend about it?
The only benefit is you being engaged in your sleep. So these apps on the watches, they're okay. They're getting better. What I tell my patients, because we get asked this a lot in clinic, is if it says it's bad, but you feel good, pay no attention to it. They are consumer devices, and they are specifically designed so that you check them regularly. And in fact, I heard from a fellow sleep colleague in Toronto, has a friend who is on the design team for Fitbit, or one of them, and they had multiple different algorithms, and some of them work really, really well when you compare them to actigraphy, but people don't look at them as much because it's boring if you sleep really well. So it actually works better. It has more user engagement when people are like, oh my goodness, oh, I only got this much N3 sleep. So you have to really, really use it with a grain of salt, because their number one driver truly is user engagement, and their secondary driver is the actual data. That being said, they are getting better. But if it says your sleep is bad, but you feel good, I wouldn't pay attention to it.
Dr. Enright had a question about melatonin in the chat.
Right. Sorry, my chat closed. Okay. Could you speak about the use of medications such as melatonin for sleep? Absolutely. This is a really huge topic in circadian medicine. So the bottom line is melatonin is a circadian medication, not a sleeping medication. As I mentioned, it's high in nocturnal and diurnal animals at night. Melatonin can be used when you want your circadian rhythm to align with sleep. So using it to mark the beginning of sleep can be somewhat helpful. And there is a mild drowsiness kind of hypnotic effect. However, the effect of light is far and away way more impactful. So when I talk to patients about that, I say use light first. And then if that's not effective, you can use melatonin, but the melatonin really almost is a placebo. And if you're going to use melatonin, you have to use it in conjunction with decreasing the nocturnal light to kind of bookend your sleep into that circadian period. And then the last thing to mention as well with that is that people who are phase advanced who use melatonin may actually make their problem worse. They may advance themselves even further. So just knowing your circadian rhythm and being aware that you're using it in somebody who's a bit delayed to try to shift them a bit more forward is important. But it's a bit complex when it comes to the circadian side of things.
And other medications? For
sleep. So unmedicated sleep is better than medicated sleep, but medicated sleep is certainly better than no sleep. So the best way to treat sleep troubles like insomnia is cognitive behavioral therapy. That's come out in many, many, many trials to show that that is the best option. But there are certain situations where medications for sleep are indicated. So for example, if sleep comes along with other disorders, for example, depression or anxiety or something that is being co-treated, then medications for sleep can be helpful. In an acute reaction, so death of a loved one, hospitalization, medications can be helpful for sleep, but should not be used long term. And almost all of the medications we have for sleep are on label only for days to like a week. And we use them on this long-term basis in a way that they should not be. They're associated with falls, cognitive impairment, all of these things. So we really, really try to minimize it. Our incoming sleep fellow just did a talk on sleep in inpatients, which is a whole additional talk, and a lot of, we can really optimize that, I think, a lot better for our inpatients, but that's an aside.
And do you have a suggestion for a drug in inpatient
patients? That's a great question. The one that they're using a lot in the States is lemborexant, which unfortunately we don't have on formulary here. It's a new medication. It's a dual orexin receptor antagonist, a DORA. And what it does is, remember I mentioned orexin is the glue of sleep and wake. So it just kind of makes you flip into sleep a little bit more easily. The reason why that's a particularly good one is because it's not a sedative. It's not clearly associated with increased falls or cognitive troubles or delirium. So really, really great medication, but new, expensive, and unfortunately not on formulary here yet. For the ones that we have on formulary, trazodone's okay in inpatient, never as outpatient. What I recommend is, if for my residents, if they get called at 2 a.m., nothing, acknowledge maybe a little bit of magnesium, something placebo, and then put a PRN for the next night. You shouldn't be giving sleeping medications anytime after 8 hours of anticipated wake time.
Dr. Chen? Can you just repeat the question for the people online?
So the question was anything that we can do to modulate the effect of age on specifically sleep pattern, right? So understanding the circadian rhythm. So it's again, quite a complex topic, but your melatonin rises when it's time to start to go to sleep about 2 hours before, and then it falls in the morning. And so in phase delayed people, we do melatonin and light early and then late. And you can actually reverse that in people with phase advance. So people with phase advance, if you give them light at night, it will push them later. So for example, people who are more phase advanced, they're going to bed at 7 a.m., they're waking up at 5 a.m. What you can do is they have a bright light, 10,000 lux, 2 hours before bed, that will push them 1 to 2 hours later. And then if they wake up early, like 2 hours before that anticipated wake time, for example, 3 a.m., they can even take a dose of melatonin then and play around with that time. The issue is if you take it before versus after that inflection point, that temperature nadir, it will have different phase effects on how it changes the circadian rhythm. So for phase advanced, you do want light in the night plus or minus melatonin in the morning, as long as it's not too drowsifying for the rest of the day.
And just one last question, the source and dose of melatonin.
Unfortunately, in Canada, we do not have prescription melatonin. They do have prescription melatonin in other places like Europe and Australia, and in the States, they even have melatonin agonists, Ramelteon and Tazemelteon. So for us, it's over the counter. Nobody should be taking more than 1 to 3 milligrams, except for REM sleep behavior disorder patients. That's an aside. Otherwise, nobody should be taking more than 1 to 3 milligrams. People are on insanely high doses. And what I tell people is to just, if it's not working for them, they can try a different brand. I have found that those Costco gummies, people seem to really like them. I'm not sure if that's because it's more bioavailable or not. They have done studies looking at all the different brands. There's a study out of Guelph, and the dose actually ranges anywhere from 46% of advertised dose to 412% of advertised dose. So it's really a bit messy. I'll usually tell my patients 1 to 3 milligrams, try a different brand if that one's not working.
Great. So 8:31, thank you on behalf of our division, Dr. Charlesworth. Yeah, I'm looking at the comments. I think everyone really appreciated your talk, learned a lot, and hopefully we can have you back for more education in the future.
Thank you.